it's the last choice of the day anyway. And today our speaker is Dr. Kalamba Narasimhan, who is the head of electrophysiology and a consultant cardiology in the AIG group of hospitals in Hyderabad, India. He is very well known to this audience as he had in person represented Indian College on behalf of them on many different occasions with interesting lectures. He has also participated in many workshops along with us. And so today the topic which is given to him is epicardial VT ablation. Over to you, Dr. Narasimhan.
To the Sri Lankan Heart Association for the kind invitation. And it's indeed my pleasure and privilege to share the screen to this august audience. Over the next couple of minutes, I'll talk about the steps of epicardial catheter ablation. First of all, I would like to emphasize it is a very safe procedure. So don't think that epicardial ablation is a serious thing. Consistently, we can minimize the complication to less than 1%. So why is this? Why should we go to the epicardial surface? It's because a third of patients, approximately 30% of patients with ischemic cardiomyopathy, they have circuits on the epicardium, and the catheters that we use on the endocardial surface, we cannot get rid of the epicardial circuits. And this is more so if you have persons with obstructive hypertrophic cardiomyopathy, non-ischemic cardiomyopathy, and sarcoid, where the epicardial circuits are predominantly epicardial, the VT circuits. Some of the clues, the ECG clues, are this pseudo delta, very to the peak. It occupies more than 60% of the VT QRS duration. That should make you suspect that you are dealing with an epicardial circuit. So presence of pseudo delta, or what is known as the maximum deflection index, more than 60%, or a complete QS complex in lead 1, all these things should make you suspect you're going to have an epicardial VT, and you should be prepared for ablating them from the epicardial surface. Now, like everything else, understanding the anatomy is essential for safe access to the epicardial cavity. So, as you know, epicardial cavity is a virtual space that lies between two serous pericardial layers. And there is this transverse sinus between the aorta and the pulmonary artery, and the oblique sinus in the posterior portion of the atrium. And generally, the safest route to access the epicardium is from the subxiphoid process. And there's a French surgeon by name Larry who used to access the epicardium through this space without going into the diaphragm. So there is a potential space between the xiphoid process and above the diaphragm, a very small narrow triangle. And if you go through this, you are unlikely to hit any other organs and cause any collateral damage. We have been imaging pre-procedure to obtain a CT scan. If you can see this is the internal mammary artery, which divides into superior epigastric artery, which runs in the epigastric, the rectus sheath, and you should stay away. And this is the xiphoid process. So your access point should be close to the xiphoid process, because if you move farther away, there is a potential to hurt this artery, which is the superior epigastric artery. So try close to the angle between the last rib and the xiphoid process. That triangle should be, you palpate and localize. Now the angle of entry of the needle would depend on whether you are going to access the posterior portion of the pericardium or the anterior epicardial space. So generally, it is much safer to reach the anterior surface of the epicardial space in which case you start lower down and make it very shallow. Whereas if you have to go posteriorly, it has to be more vertical puncture to reach the posterior surface. So subxiphoid method is the most commonly used, and even though people have used micropuncture, I would strongly recommend using the 2E needle which the anesthetists use, because it has a bevel and you are unlikely to cause injury to the cardiac structures because the hole is facing upward. So depending on how you suppose the guide wire will come in this direction, depending on how you position this bevel. If you want to access the anterior surface of the epicardium, the bevel should be facing the ceiling of the room so that as you puncture, the wire comes out into the anterior surface. If you want to go it laterally, turn the needle in such a way that the wire comes out, exits through this aperture and goes laterally or posteriorly. So this was the patient lying supine. You can see the anterior sternum, and this will be the angle of entry into the epicardial space. And remember, if you position it properly, you don't have to go through the diaphragm. You go slightly above the diaphragm if your needle is shallow and going towards the anterior epicardial space. It's extremely important to know the patient's history about prior open heart cardiac surgery or any transient pericarditis. This is important when you deal with tuberculous VT, which we see it in occasional situation. And we always try to, whenever we are trying to do an epicardial access, it's better to take it upfront before giving heparin to this patient. Because you do a transeptal, fully heparinize the patient and then access the epicardial space, then it's not a clean stick and you are likely to have continuous wounds in this situation. You can use a steep LAO or a left lateral projection to make sure that the bevel is facing quite close to the sternum and the needle exits. Use of long guide wires to fully encircle the cardiac borders are important. Don't use short wires. Use a long guide wire, say, for example, that comes with the SL1 sheath or a Mullin sheath, so that you can completely go around and have a big loop around the heart to get into the epicardial space. Never leave an epicardial introducer. So when we have an introducer and sheath, never leave the introducer in the epicardial space, because that is a sharp object with cardiac contractility. You can traumatize either the epicardial vessels, veins, or the myocardium. So it's always to just leave the wire. And if you put a sheath, immediately take an ablation catheter through the sheath. Don't leave it exposed. So this is what I meant. So whenever you want to go to the anterior space, you need to start lower down and make a very shallow puncture. On the other hand, when you want to go posteriorly, you make the angle in little more vertical so that you can reach the posterior. For example, patients with circumflex infarcts, inferior wall infarcts, where you want to directly reach, you may choose this approach. Whereas ARVC, patients with Brugada, we try to access this anterior space. So long xiphoid process will be an impediment. Sometimes patients will have distended colon that will interfere with this axis. So just taking a deep breath at the time of advancing, so remain very shallow, close to the undersurface of the xiphoid, and don't go deep in these kind of situations. If this you find on the table, it's prudent to take a steep lateral and stay away from the gas shadow of the transverse colon. So it's important to have a deep inspiratory breath hold. For example, this patient, you can see the transverse colon. If it was done in the end expiration, you would go through the colon. Whereas with the end inspiration, you find that the diaphragm comes down and the colon gets pushed out. So if the patient is fully anesthetized, ask the patient to, anesthetist, to give a deep, increase the inflation of the lung so that the diaphragm comes down and you can safely access the epicardial space. So cardiac pulsations can be the moment as you advance, don't keep injecting contrast right through. There are two ways of doing it. We just advance the needle up to the silhouette of the diaphragm, and you can start feeling the pulsation or the respiratory movement. And at that stage, inject a small amount of contrast. Because if you start injecting contrast right from here, the whole area becomes messy and you can't visualize. So just go through, and as you are going, there are two ways of doing it. One is to feel the pulsation. The other option is to put a little bit of saline on the needle. As you go towards the thorax, the meniscus will start oscillating. That will tell you where you're entering the intrapericardial space or above the diaphragm. So the moment you inject contrast, you'll see a layering of contrast like this. And as long as if you're below the diaphragm, below the pericardium, the contrast will be just linear staining like this. But the moment you reach the pericardial surface, you will have a layering of contrast on the inferior border. The moment you see that, you advance the needle and you can get into the pericardial space without much of a problem. We find the pre-procedural imaging, you can sit with your radiologist and plan your procedure, because you can understand a phantom trajectory. You can ask the radiologist to draw a line and say, what is the safest way that I can introduce the needle to enter the pericardial space? So the radiologist can give you the safe route of entry. How far should be the angle of entry to the xiphoid, and how steep should be the angle. So the site, angle, and depth of puncture is first assessed pre-procedurally to minimize the collateral damage, and make sure that the pre-procedural CT is obtained in end inspiration so that you can mimic the same thing on the table. We have used this simple technique in our patients. Just take a sterilize this protractor and send it to the, and get it before, and you use the same angle which the radiologist has given you and enter. For example, in this patient, the radiologist told us that 55-degree angle of entry is better. We just enter through that angle. Once you enter, slightly after initial entry, we again make it a little more shallow. We move the needle a little more, because initial entry is a little deeper, and then we make it shallow so that you don't enter the diaphragm, you stay in the Larry space. The needle bevel always is pointed away from the cardiac border so that you don't hurt the cardiac structure. In this study that we did, we validated that our angle of entry exactly mimicked what we wanted to do, and we were able to execute within about 1 to 2 millimeter error. But that was quite safe for the entry. Mapping can be performed using both fluoroscopy and 3D mapping systems, and the areas of scar have low amplitude electrograms. One caveat is, as you go towards the base of the heart, near the mitral annulus or tricuspid annulus, you will have a lot of epicardial fat. So the amplitude may be low because of the epicardial fat. That doesn't mean there is a scar. But what is more important is to look for fractionation or late potentials. So you are likely to see low amplitude because of fat, but you will never ever have fractionation of the electrograms. This is one such patient with sarcoid with a posterolateral scar. You can see that there is a scar in the posterolateral area, below 0.5 millivolts, and we have entered the epicardial space and ablated successfully the VT in the posterolateral LV. And we induce the VT and get a good mid-diastolic potential. As we ablate, the VT terminates and you get a sinus rhythm. But you can see a lot of late potentials even in sinus rhythm. This is a patient with a large epicardial scar in the posterior area of LV. You can see a late potential there. So whenever you have the posterolateral LV, this is where the phrenic nerve runs. So what I've labeled here, we pace at high output and tag all the areas where the phrenic nerve is captured. So I can't ablate these areas for fear of causing a diaphragmatic palsy, and therefore we need to make sure you map the phrenic nerve, ask the anesthetist not to give a paralytic agent when you plan on an epicardial procedure, or even if they use a very short-acting agent and reverse it. And then tag all these areas to make sure that you stay away from the phrenic nerve. And these are nice epicardial signals in a patient with sarcoid VT, which may confirmed by pacing and inducing the VT, and you can pace map and get the exact morphology on the epicardium. However, as you saw, there are a lot of areas where that phrenic nerve was getting captured. So we introduced a balloon in the pericardial space, separated the pericardium away from the heart so that we can safely ablate those areas without the fear of causing phrenic nerve injury. Very, very rarely, you may have a lot of adhesions. This is common in patients who have post-bypass or a lot of adhesions due to previous pericarditis. We'll first localize the VT in the lab and then call the surgeon to expose that area. You take an angiogram, because surgeons are always familiar with the angiographic anatomy. You take the angiogram and say that this area of VT is coming close to the OM1 or OM2. They will plan the incision accordingly. This is a surgeon holding the catheter, ablation catheter, which is taped to his finger, and you are irrigating from so that it doesn't get heated up. Simultaneously, we are irrigating the tip of the surgeon's finger. You can ask the surgeon to map with this and successfully ablate the VT. Another area where we find it useful is in children, where this is a child, I think it's about a 4-year-old child with incessant atrial tachycardia coming from left atrial appendage. You find that the endocardial catheter was there, but the signals were not good, and we were not able to successfully ablate. We went epicardially and ablated this atrial tachycardia successfully. And this is the electrogram. I would just skip on to this next case. So monitor for phrenic nerve. And the other thing you need to always be aware of, you need to stay away from epicardial arteries before you prepare for energy delivery and ablation. Maintain a safe distance of more than 5 mm from epicardial vessels when performing catheter ablation. Catheter orientation is extremely important. So when you put a catheter in the pericardial space, it may be touching the parietal surface. You'll still have a contact, but your catheter ablation will be ineffective. You should make sure in fluoroscopy that you're hugging the heart and the catheter is pulsating with the cardiac movement to make sure you have adequate contact. So catheter orientation is extremely important to cause a successful lesion. Perform ablation using irrigated radiofrequency ablation with a very reduced flow rate. Of late, we have been using half normal saline for causing a deeper lesion. This is a young adult with Brugada syndrome, resuscitated VF. This is, as you know, I am not going to go into the mechanisms. This kid came with multiple episodes of spontaneous VF requiring shocks. And endocardial mapping, and then epicardial mapping. You can see this kind of late potentials on the epicardium. So you enter from the anterior surface. This is anterior surface of RV. Wherever I have tagged in this pink area, the orange dots are all late potentials. You can see a small fragmented late potentials. So what we do is we take the end of the ST segment. Whatever comes in this segment as abnormal potentials, we tag this and ablate those areas for successful catheter ablation. This has been validated by several centers. Make sure you take an RCA angiogram and stay away from the RV branch and make sure that luckily most of the Brugada substrates are very high up on the RV outflow, and it's high above the RV branches well below this site. The clues are that you get a fragmented electrogram, which occurs at the end of the QRS wherever the ST segment is elevated. The other thing after catheter ablation is successful, we instill a little warm saline in the pericardium, because as you know, the ITO current of Brugada syndrome is highly temperature sensitive. So if you instill pericardium warm saline, if you have left any substrate unablated, it will become more manifest. But if you have completely ablated the Brugada substrate, you will find no ST segment elevation. At the end of the procedure, we always use this to validate that we have successfully ablated a Brugada. It's again very important to maintain a safe distance from we take a coronary angiogram at that same time, have a catheter well deployed into the epicardial space, preferably a deflectable catheter, so that you can take it wherever you want and take an angiogram and make sure your catheter is nowhere near a epicardial coronary. Second thing is, if you have irrigated a lot, this is an animal experiment. If you have irrigated and there's a lot of pericardial fluid, you won't form a lesion. So make sure that before you deliver RF, you are completely dry the pericardium and then deliver RF. So this is without pericardial fluid, you see a deep lesion. With pericardial fluid, the lesion becomes very small. So no pericardial fluid, large lesions. With pericardial fluid, very minimal lesions. You should always drain the pericardial space before ablating this. And validate by high output pacing to make sure the phrenic nerve is not captured. And we can safely deploy a balloon into the pericardial space and position the balloon between the catheter and the ablation site and move the pericardium away from the heart so that you can successfully ablate. And once you ablate, especially young patients develop severe pericardial reaction. Whenever you are anticipating epicardial ablation, it's better to start these patients prophylactically on colchicine 48 hours before the procedure. If not, at least give it post-procedure. And before we come out, we put in a pigtail in the pericardial space and inject a long-acting steroid like triamcinolone before we pull out the pigtail, so that this pericardial reaction is well attenuated and patients don't suffer from pericarditis. So I would like to conclude, epicardial ablation is a useful adjunct for catheter ablation of arrhythmias. If we take some simple precautions, it can be safely performed for a wide variety of conditions. And I would like to thank the Sri Lankan Heart Association, Dr. Asanga and Rohan, my good colleagues, for the kind invitation. Thank you very much for the kind invitation again.
Thank you, Dr. Narasimhan. As usual, you have made a very complex procedure, explained it very simply for us to understand. We have a bit of time, so maybe if there are any questions from the audience, we could accommodate a couple of questions.
Thank you.
Hello, sir. This is Susita Amarasimha.
Hi, how are you? Yes.
Thank you very much for that very enlightening talk, sir. Since we have a few minutes, what is your, in selecting patients for epicardial ablation, what is the breakdown that you have, how many patients with VT versus how many patients with things like WPW, outflow tract? What is your experience there, sir?
Most of the epicardial ablations are for VT. And we have, whenever you have failed WPW, we would have done probably about 5-6 pathways going through the epicardial space, but it's very uncommon. Atrial tachycardias, especially appendage tachycardias, when you go from inside out, your potential for injury is higher. When you come from outside in ablation, it is much safer. So again, rarely you have these situations. One of the useful things is what we do is before you consider epicardial, are you able to see my screen?
Yeah, can see.
Okay. So we introduce a guide wire into the venous branches of interest. For example, in this patient, distal coronary sinus was early. So we put an endocardial catheter here and then before getting an epicardial access, we map from the vein using a guide wire. If this area is not early, but endocardium is early, you go to the endocardium transeptal. Whereas this gives a rough idea even before you make a puncture. These are some useful tips that you can take up. But most of the ablation is in ARVC, Brugada, sarcoids, hypertrophic cardiomyopathy, these are all predominantly epicardial circuits. And rarely circumflex infarcts, we have seen more often having epicardial circuits.
Okay, thank you, sir.
Can you just let us know, Dr. Narasimhan, one of the things that we worry about when we try to do epicardial ablation is that we might injure the heart as we go in. Like, for instance, because sometimes the RV wall is very thin. Is there any kind of way we know whether we are actually entering the myocardium rather than the space? Any kind of...
Thank you very much. This is a very useful question. So initially, if you're worried, this is a common problem when you do ARVC where the heart is, RV is very thinned out. One thing I would suggest is take an angled pigtail and put the pigtail on the inferior surface of the RV. As you are puncturing, ask someone to inject into the RV and then you advance the needle close to that area so that you will know where you are. Second thing is, even if you get into the RV, generally nothing happens. You aspirate immediately, you keep the wire inside, you can immediately come back a tad and advance the wire. Generally nothing happens. Because patient is not heparinized, and these patients just delay the heparinization.
Thank you, Dr. Narasimhan. That's a nice explanation. Since we don't seem to have any other questions, we'll wind up the session. And thank you again for taking your time at this particular late Sunday evening to be with us. And it's a pleasure always to have you with us. And we have had several times we've been here and we have... Okay, good night.
Thank you so much.
Good night. Thank you.
Good night. Good night.
Announcements? Do you have any for tomorrow? Do you have any announcements?
Thank you, everybody. This concludes our Sri Lanka College of Cardiology's Fellows course. Please join us virtually tomorrow for the General Cardiology course. Thank you. Good night.